A long time ago, I was working on a lecture for medical students, for second-year medical students, to try to introduce them to the various psychiatric diagnoses and broadly talk about causes and treatments. And it came to my mind that the standard information on depression is, I would say, very incomplete. And so I wanted to try to broaden some perspective of the students. Why I say that, particularly, I think that the depression story is incomplete is that my background also includes more years than I could count being the kind of like the default consultant for refractory depression cases in the Pacific Northwest. In Oregon, I counted them up. Let me back up. In depression, the most effective treatment known to man is electroconvulsive therapy, which I actually think we should rename electrotherapy because we actually eliminate the convulsive part. But it has, as people know, a bad rap. And in some areas of the country, very few people actually bother to get themselves trained in it. So while I was in Oregon, I was one of 7 doctors for the entire state that would actually practice the dark art of electrotherapy. And I did so, I mean, and just as an aside, I grew up in a medical family, so I have been exposed to lots of gross stuff from an early age. In medical school, I only got nauseated 3 times in the entirety of my medical training, actually. And one of those was the first time I saw ECT. I thought this was the most barbaric and horrible idea that we could ever have come up with. But my patients got better. I mean, these folks were about ready to die because nothing else was working. And then when I say better, they were restored with no discernible side effect, and I thought this was just amazing. I still think it's amazing. But to come back to, because I was one of a handful of doctors that would do these things, I became a default consultant for refractory depression cases on a large scale, and I learned that what most people learn about depression is incomplete. So the second thing that came up actually recently is in my echo, there was a question, why do I see so many lamotrigine prescriptions in my practice? And one of my answers was because I think there's an over-reliance on trying to fix things with medications, which is reflecting, again, the fact that we don't really teach what we used to teach before we had modern drugs about what causes depression and what makes it better. So some facts, there's a very high rate of non-response to pharmacotherapies. Actually, the charitable estimation of response rate is about 50%, maybe 60%, meaning that 40% or 50% or 60% of people with depression that get pharmacotherapy don't get remission, and oftentimes they get very little response. So that's a big problem. Messaging about how to interpret treatment non-response, no matter the diagnosis, is usually incoherent, especially in psychiatry and especially when it concerns major depressive disorder. And in other words, we don't really have algorithms in psychiatry that are well publicized to say, do this treatment first, and if this fails, try this, and if that fails, try that. They exist in some sketchy form, but when it comes to depression, if they exist at all, they're hardly publicized or hardly widely agreed upon. And there is, I say seemingly because this reflects my observation as a depression consultant, very widespread, I will say it, pharmacological abuse. As an aside, keeping track on time, as an aside, I at one point I had to start taking Benadryl before I would be on call because I would keep getting all these calls. I have so-and-so, they're depressed and suicidal, they need admission. That was the extent of the evaluation. I would ask for the medication list, and I wish I was joking, but invariably they would be on 3 antidepressant medicines or more, and not infrequently they would be on 2 or 3 or 4 times the maximum recommended dose. So no wonder the person is showing up to the emergency department anxious and dysphoric. And the other thing that happens when we only talk about depression as a medication, as a medical problem requiring medical treatment, is that it doesn't work. And the longer we spend diddling around with medicines, the more our patients are not getting better. So I hope to impress on you that we don't need to have people suffering to some degree with depression for years and years and years. We can do better if we think more broadly about it. So to sum up what I'm about to tell you, not all depressions are the same. You can say that. You can basically insert any diagnosis where depression sits and say about the same thing for any psychiatric condition. But we'll talk about depression. Not all depressions are the same. Some depressions are very much medical problems. They are very much sort of genetically destined states. And those depressions gratefully respond very well to somatic treatments. And I'm going to talk in a second about somatic treatments and those mean obviously affecting the body. The most common somatic treatment in depression is pharmacotherapy, although we can also use brain stimulation therapies such as electroconvulsive therapy or magnetic stimulation and some others that aren't FDA recognized. That is opposed to what's called psychotherapy, which are therapies directed at, if you will, psychological or non-body elements of depression, and those actually I'll show you are very effective. So some depressions are very much genetically or biochemically determined, and they get better almost no matter what the somatic therapy. But a lot of depressions aren't, or many depressions have a mixture of a biological component and a big psychological, social, spiritual, environmental meaning and purpose factor. So you've all heard about biopsychosocial model, but when the rubber hits the road, we tend to rely on bio. A central message here is that the other parts actually are important parts. So back to my medical student lecture, I came up with this as a diagram. I call it the depression stadium. So the game looks the same. If you're viewing depression as an insider or an outsider, it's broadly the similar script. I don't feel good. I have no energy. I'm sad. I feel myself as a failure. It's the same outward appearance, but there are different pathways to get to that state. So it's easier to exit the way you came in. So some depressions are very much, serotonin abnormalities. We know this because serotonin acting drugs can very much help many people. So those drugs are telling us that those depressions probably had something to do with serotonin. You enter by a serotonin problem, you can get out by a serotonin therapy. But if you have, on the lower right corner, a neurotic personality, which is to say one which is predisposed to rumination and worry, then maybe tweaking the serotonin will help some, but it's probably more effective to just try to work on the personality factors that got you into the stadium. And you can have a relatively functional personality and a relatively intact serotonin system, but if you are living in insecure housing by yourself in a foreign town with no friends and a demanding job and whatever, you're going to wind up with something that looks like depression. And probably addressing those environmental factors are going to be the easiest way to get out of that. So they don't, I made this up. It's not appearing in psychiatry textbooks, but I would wish that something like that does. I think it would make everybody's understanding of depression and treating it go a lot more sensibly and smoothly. So now I'm going to be critical of the over-reliance on pharmacotherapies and medical models. So we have drugs, and 20 drugs maybe that have around that number that have approval for the treatment of depression. No matter, it seems like a lot of drugs, but really they do one of three things. They can modulate serotonin, norepinephrine, or maybe dopamine. So 3 neurotransmitters in a brain which has 100 trillion synaptic contacts, uncountable different circuits, billions of cells, and over 100 different signaling chemicals. So to imagine that we can solve most depressions by just managing 3 neurotransmitters is a little bit of hubris. We tend to over-rely on this narrow spectrum of treatment options. As I said, if you pull off whatever antidepressant medication from the shelf and give that to the person who's walked in with the first complaint of depression to your office, you can expect about 50%, maybe charitably 60% response rate. Remission, which is to say the abatement of symptoms, is going to be a lower number than that, but you'll have in about half the cases reports that things are getting noticeably better. If you take that other half that don't get better and give them some other medicine, then your response, the likelihood of significant response goes down to between 15% to 20%, according to the best estimates of pharmacotherapy algorithm. And if you haven't responded to the third treatment, then it goes down to low teens in likelihood of success. So medicines, they work well if they work, but if they don't, then second or third attempts are diminishing returns. Contrast with this electroconvulsive therapy data. Again, not all depressions are the same. So if you look at all depressions, then you can get maybe about a 70% or higher response rate from electroconvulsive therapy. If you take only those cases of depression that have the so-called melancholic presentation, which is to say sleep disturbance, appetite loss, weight loss, very low activity, and psychomotor retardation, then this is an unbelievable number, but it's true. 80 to 90% have response. And as I was an electrotherapy practitioner, I would keep track of my own response rates, and I was 95% in melancholic depression. And response is not just response, it's actually getting your life back. So the response and the remission rates for melancholic depression look very similar. But very few people are actually offered that treatment. And we have a less, if you will, invasive or less spooky treatment called repetitive transcranial magnetic stimulation. And actually, it's less effective than ECT, but between a 45 to 60% response rate is actually pretty good, especially since it doesn't involve general anesthesia. So there are within the somatic treatments all sorts of ways to make a depressed person feel better. Not all of them. In fact, the least effective of them are with pills. But altogether, we don't have to just rely on addressing the body function. We can actually do psychological treatments. I apologize, I didn't have time to get the whole list of them, but psychotherapies for depression are effective. The one that has arguably, one of the best databases for efficacy is called cognitive behavior therapy. And this is a 2012 meta-analysis, and the analysis of meta-analysis actually, and response rates to CBT actually better than medicine, 51 to 87%. And because CBT involves actually learning about how you think when you're depressed, you have the possibility of getting closer to a root cause, especially if the person's depression is psychologically based. Part of why we have such a difficult time thinking about depression is because my field of psychiatry keeps changing the game. So in 1970, if a psychiatrist was saying you have major depression, that psychiatrist meant specifically you have had a sleep disturbance. You're not sleeping. Typically, falling asleep is easier than staying asleep. Typically, people would wake up in the morning, no longer actually in the criteria, they would wake up with the best mood of the day, and then it would deteriorate. It would wake up with the worst mood of the day, and then it would improve as the day goes on. Appetite was lost, weight was reliably lost, and there was just a general slowing of speech and activity. Now, hypersomnia or insomnia, loss of appetite or increased appetite, psychomotor agitation or retardation. These are actually any form of change now qualifies you for a definition. Incidentally, that's probably why we see the placebo response rates rising in clinical trials of antidepressants these days, because essentially, in my view, we're simply labeling as depression a variety of forms of sadness. And when patients are not responding to antidepressant treatments, these are things that are oftentimes missed. Personality factors, a gigantic overlooked factor. Analyses, I was trying to find the papers that I stored in this. I couldn't find the exact references, but they exist. Estimates of personality disorder or significant personality pathology are that those things are present in 70% or more of so-called treatment-resistant depressions. So missing that is identifying that frequently unlocks or solves the puzzle. Then, really paying attention to quality of relationships and other sorts of life things like, do you have in your life the possibility of having leisure activity, exercise, time to sleep if you want to? Do you feel like you have meaning and purpose in your life? And I'll mention here substance use as I was putting this bullets together. Thought I would comment upon another thing I observed with great frequency in my Oregon practice. Cannabis has now got a brand image rehabilitation. I kind of say it got sent to rehab in 1937, and now it emerges with a new sort of brand image as medicine. And a lot of my non-responding patients that I got for consultation were, they told me, well, yeah, I use weed, it helps me. And I think if you listen to them very carefully, what they're telling you is that when I am intoxicated or mildly intoxicated, I have an elevation of my mood. So in short term, absolutely, it's a mood elevating thing for most users. But I didn't say this to my patients, but I'll tell you now, there's actually a difference between being high and being well. And but websites like Leafly.com don't actually address that. They focus on short-term things. The data actually, if you go looking for clinical studies and clinical trials, human beings, cannabis, depression, there are zero clinical trials of cannabis as an antidepressant treatment that I could find. And in fact, you find evidence that it may worsen depression or make recovery from depression less likely. People with depression given THC in a laboratory have high rates of dysphoric responses. So, it's I don't think we have enough data to say it causes depression. I think in some people it might, but those might be a minority. But certainly we have a fair amount of data that say that if you're depressed and you're using cannabis regularly, you might improve your odds for success by giving yourself a vacation from it. And so to sort of tie together this little rambling tour of the forgotten areas of depression. We'll remind you folks that medications all times and everywhere are doing two things simultaneously. We're using them primarily to get people better, but at the very same time, they're telling us what's happening inside the body. They're actually informing you as to the cause of the illness that caused you to prescribe medication in the first place. So if you give somebody with depression a serotonin augmenting drug and their depression gets better, it's reasonable to infer that that depression has something to do with serotonin. But if you give a person a serotonin acting drug and they don't get better, and especially if you give them a second round of the same kind of drug and they're still not better, this might be nature's way of telling you that serotonin deficiency, quote unquote, is probably not highly relevant to the cause of depressive symptoms in this individual. So generally, I think my rule of thumb is use a medicine, know the right dose and the right duration of treatment and what it's doing inside the body. And if the person's not getting better, then odds suggest that that's not the pharmacological strategy that's going to unlock the problem. So in my practice, if I'm going to go to a second antidepressant drug, I will probably not make it a second round of a serotonin reuptake inhibitor if they didn't get better with the first one. And if they haven't gotten better to two, then I would please ask all of you, please do a careful assessment and make sure you haven't overlooked personality, other diagnoses, maybe medical problems, and a comprehensive review of environmental, psychological, and social factors, because those things are usually what's going on. And if you're convinced that there's something to do this, something about this is biological and needs biological treatment, then please don't hesitate to refer them to brain stimulation treatments, because my heart would break when I would treat these people who had been suffering for 5 years with diligent physicians who are trying very, very hard to combine medicines, whatever. I can get them better in 3 weeks with a little bit of electrons. So there's that. Oh, and the last thing to say is that I think that the other great damage that nobody but me is really pointing out right yet is that when we are focusing on medicines or talking with patients about medication interpretations for their depression, we run a great risk of disempowering them. I put this image up because it's kind of like I'm stranded on a desert island. If my depression is biologically determined, and I need some medicine or somatic treatment to get me out, I'm just going to be waiting for the right drug combination to come along. And that's really sad, because we practice psychiatry for more than 100 years with no medicines whatsoever. And we learned very well that a lot of depressions are psychologically based. And so we can give people the tools to understand their minds or their lives and to take some power in their moods. And so I think when society or practitioners in medicine are talking about medicine, we need to make sure that we don't give the message that a person lacks the power to modify their moods internally, or can change their course of life through their decisive actions. So that's my comments on